Good morning and good afternoon, wherever you are. Welcome, hello, and thank you for joining us today for the POCUS Certification Academy and today's POCUS Bytes webinar. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for any comments you may have throughout the webinar. The presentation will include a PowerPoint and time for Q&A in the end. And today's topic is biometry measurement and IUGR. And our speaker is Rawan Alsukairi. And welcome back, Rawan. She joined us last month for our first webinar, and this is the second webinar out of 3 that she will be hosting with us. Welcome back, Rawan. We're so excited to have you. Thank you so much for joining us.
Thank you, Daria, and thank you, everybody. Good morning and good evening, everyone. I am glad you made it. So last time we have talked about first trimester for ultrasound, and today we are touching on second trimester ultrasound, and then the upcoming one would be the third trimester. So welcome back for those of you, and any one of you who have missed the first trimester, you can find it in POCUS website. So the survey of OB scan after 12 weeks of gestation, at this time, we're gonna have to be again ensure that there is viability, measuring the heart rate, the baby is still alive, amniotic fluid volume, it could be pretty much too soon at this time, but we're still gonna look at it. Fetal presentation, still also too early, but it's one of the things we still start to have in consideration. Fetal biometry, which is speaking of growth, how the baby is growing, and placental position. Those are the major 2 points we are going to be speaking briefly about today. So our objective would be placental implantation, placenta previa. We're going to have to be understanding the risk factor and outcome of a placenta previa. Normal umbilical artery Doppler and ductus venosus Doppler, as well as intrauterine growth restriction, and the biometry measurement during second trimester. So the biometry parameters, we're gonna have to be, in order to know the weight of the baby or how the baby is growing or not, we have to be measuring these parameters, which are biparietal diameter, along with the head circumference. Both of them, we do them at the same level of the baby's head, and the abdominal circumference and femur lengths. Adding all of those measurements together, the ultrasound machine is capable of telling you how the baby is weighing, how much it's weighing, and how big it is in weeks for gestational age. So at the beginning, we want to know how to measure the biparietal diameter and head circumference. So at this image, you see the biparietal diameter. We have to have a transverse image of the baby's head at the level where you see the skull clearly. It's hyperechoic in the image, and it has to be at the level where you see the falx cerebri, the thalami, and cavum septum pellucidum. Having all of those landmarks make you know correctly you are at the correct level. I don't want to see the cerebellum. If I see it, you mean you are angled wrong in your probe. So you have to get it out of your picture where you definitely see CSP and thalami. And then where I am going to measuring the skull, as you can see in the skull, inner to inner, and at the same time, at the same exact image you did freeze, you are going to do the head circumference. It has to be hugging the skull. Unlike the PPD, the head circumference, as you see, the blue line is hugging the entire skull at the same level where I see CSP and thalami of the baby's head. And then moving down into the abdominal area, we have to do the abdominal circumference also. With this one, it has to have the landmark, the stomach and portal vein, and it has to have the spine as well in the image. If I don't see the stomach and I see kidneys or adrenal, I know you are in wrong plane, you are not at the correct level where you can measure the abdominal circumference. Then when it comes to the femur lengths, moving down further in the lower extremity, the femur is the largest bone in the baby. You have to also be scanning the most anterior bone because the baby has right and left leg. So one of them gonna be more anterior, the other one is more posterior. I never ever wanna measure the posterior bone. It has to be the anterior one. And you have to be measuring from the tip of the bone to the end of it, the longest axis. And while you are measuring, you have to know before you do all of those measurements, when we enter the patient data in the worksheet or prior to starting the exam, we have to be determining her LMB. And we plug the LMB. You cannot proceed with any exam without having LMB in the machine, because LMB is gonna let me know how far she is in a pregnancy or how many weeks the baby should be measuring. So suppose the LMB told me the baby is measuring 20 weeks, then as long as I am doing each one of those measurements, I am gonna be, while doing PPD, I will see now how much is the PPD giving me. Is it also 20 week or it's less, 19 and 5 days? Those can be random. So there are many protocols in a lot of places. The majority would be like when you do the measurements, you're gonna have to obtain 3 measurements of each, and then the machine is gonna give you the sum of all of those 3. So it's highly important to be keeping your eyes on those measurements. So for some of those beginners, they don't understand the rule, or you might not get it until after you have been in the field for years or for at least some months to grasp the idea of not being of why you should not be proceeding into any exam without having LMB, which means you are going blind and you don't know if the baby is growing or if there is any abnormality. Is it restricted from growth or way bigger than how much it should be measuring? So moving forward, again, here is a closer look to the level where you have to see the CSP, cavum septum pellucidum, which looks like a box, and you have to have the thalami. I have a clear image in the next one in here. CSP and thalami, you have to have them, and the falx cerebri, and the skull is so clear. Sometimes in very obese patient, you might not be able to clarify one of the borders, whether the anterior or the posterior one of the skull. At that time, you are not going to freeze and measure the image until you clarify the skull really well. Otherwise, the radiologist is going to be pissed and really mad and will let you repeat that particular image or not really consider it a good diagnostic image. So now this is question number 1, anatomy survey of the baby. When do we perform full anatomy screen? Do we do that by 20 weeks, by 13, or by 30 weeks of gestation?
Okay, we are at 50%. Almost there, so I'll give a couple of seconds, sorry. Okay.
Somebody have asked about the PPD. Actually, you're gonna measure it outer to outer. We're gonna go get back to the image. The PPD. You're gonna measure PPD outer to inner. One of them is outer, one of them is inner, but for the head circumference, it's gonna be hugging the skull exteriorly. So As far as when are we gonna make the full anomaly screen, it's by 20 weeks, so that's correct. Anatomy survey of the baby, we're gonna have to be, in order to do the anatomy, we're gonna look at every level of the baby one by one. We're gonna have to check the head, face, and neck, chest, the abdomen, the spine, and the extremities, upper and lower, right and left, fingers and toe, gender at the end. So maternal anatomy, also, we're gonna have to check the cervix. Perhaps it could be open cervix, or there is any abnormality with the placenta by the internal OS, adnexa, uterine anomaly. So for the soft markers, also, we're gonna have to be looking deeply into echogenic intracardiac focus, which is abnormality within the heart of the baby, choroid plexus cyst at the level of the head, echogenic bowel or increased nuchal fold, those within the level of the head. Ventriculomegaly also is something abnormal. Any abnormality within them may indicate Down syndrome, trisomy 21, or trisomy 18 as well. So here is the echo foci I am talking about. You can see it within the heart. That's abnormality and associated with trisomies. So that's one of the things, even if you are a beginner, it could be easy for you to detect that soon. And here is ultrasound image of the baby's level of the head. I can see the cerebellum in here, cisterna magna, and then the nuchal fold. There is a measurement of the nuchal fold. The nuchal fold is the most posterior one, way posterior to the level of cisterna magna, and it shows an increase in the thickness. That's why they did measure it. And here, why I am bringing this is the NT, nuchal translucency, that we touched on in our last webinar. This is the measurement that is done 11 to 13 weeks. It's better to be done 12 or 13 than the 11. So I wanted you to differentiate between the nuchal thickness, nuchal fold, and nuchal translucency. The translucency is different from the fold. So do not confuse the two of those. And here, a ventriculomegaly is by the level where you see the choroid plexus. You will see the lateral ventricle shows an increase of its thickness and so much fluid that we call it also teardrop sign. And here, renal abnormalities, you will see both kidneys, and the renal pelvis will look totally anechoic, which look black in an ultrasound, and it represents dilatation, where the entire kidney look hyperechoic in comparison to the pelvis. So we measure the pelvis and transverse, and we see, you can see the measurements in here, 4 and 4 millimeter for right and left kidney. And here, increased nuchal translucency in baby, this should be probably 13 weeks plus. And here is the area where the fluid is too much. This is abnormal. And choroid plexus cyst, you're gonna go to the choroids, bilateral choroids, and then you will see the cyst either unilateral or in both choroids. And you have to follow up in this because sometimes it can just resolve in itself and the baby is good to go in the next scan. So always document it and follow up on it in the next scan when the patient come back again. Second trimester laboratory values, alpha-fetoprotein is produced by the fetus, found in the amniotic fluid and the maternal serum. So it's in both area. Normal value is very different. It's variable with gestational age. Like it's not one standard that doesn't vary. So it can elevate. What caused the elevation of alpha-fetoprotein? And that's something to open eyes on. Underestimated gestational age. Fetus is older than the expected, or multiple gestations, open neural tube defect. That's why I would want to know if there is elevation of alpha-feto. Abdominal wall defect, cystic hygroma can be associated with the elevation, renal anomaly, fetal demise. So additional causes of the reverse and contralateral side, the low alpha-feto, due to overestimation of gestational age, fetus is younger than expected, chromosomal abnormalities, trophoblastic diseases, a long-standing fetal demise, and chronic maternal hypertension or diabetes. That the diabetes that she just happened to have during pregnancy. So now speaking of a placenta, it's an organ that develops in the uterus during pregnancy. It provides the oxygen and nutrition supply to the baby. It removes waste and from the fetal blood, and location-wise, it has to be attached to the wall of the uterus. And we name it according to where it is sitting. Anterior placenta, as you can see in here, as it's within the anterior wall of the uterus. Anterior fundal, because it's within anterior and fundal area of the mother uterus. Normal implantation versus placenta previa. So as I said, the placenta has to be implanting itself attached, adhered to the wall of the uterus in a correct level. So here is the placenta, umbilical cord, and here is the myometerium of the uterus. I want to see a level of the myometerium that is still clear in this side, and in the contralateral side, they look the same, which means the placenta implanted itself correctly, not beyond where it should be. So that's for the normal implantation. Placenta accreta, what happens in here is that the placenta pushed itself like if it did bite some of the myometerium area where it got adhered. So 10% of the cases happened to have placenta accreta, abnormal attachment of a placental villi. The villi are those that pushed themselves into the myometerium because of defect in the decidual basalis. It's occur in 1/500 of pregnant. Placenta Inicreta, that's more advanced stage where not only it's attached to the myometerium, but not only it's attaching the myometerium, but it's invading it more deeply. Almost 3/4 of the myometerium is gone. Whereas when it comes to the percreta, that's the severe case where the placenta went beyond the uterus, beyond the myometerium of the uterus, all the way into external organs outside of the uterus cavity, all the way into maybe the bladder or bowel area. Types of placenta previa, there are minor and major previa. So as far as minor previa, it can be either low-laying placenta or marginal placenta, whereas the major is partial previa or complete previa. We will talk about them one by one. So minor, why they are minor? Because the internal OS is not affected too much as with major previa that is covering the internal OS completely. So for those of you who are still beginner and doesn't know the internal OS or external OS, the internal OS is the one that is close to the baby in here. External OS is the one way within the exterior, more closer to the vagina. So here, when it comes to the minor previa, low-laying placenta, it's only low in location. Speaking of the location in the uterus, it's low, but really far away from the internal OS, from the internal opening. It's not doing anything with it, further away from it. And when it comes to ultrasound, what we will do, we would want to measure the area from the internal OS to the tip of the placenta to know how long this one is measuring. So this time when you discover such thing that, oh, the placenta is low, you will see this. So when you see this doing the exam transabdominally, having your transducer at her belly, you would want at this point to switch into the endovaginal, that will give you closer look. The endovaginal is going to only touch this area, which is the external OS. It has nothing to do with the internal. And while examining and diagnosing, we are now closer. We're going to have a much appreciated image with closer look that will give you better value than doing it from the belly with all the fat and really non-accurate and not really good. And I am sure if you have done it abdominally, the radiologist is going to ask you to do it endovaginally to give them much better and closer look. So that's for low-laying placenta. It's minor and really far away from the internal OS. Then the marginal placenta is really low, but also close to the margin. See how here is the margin, it's close into it. Still, the internal OS is open, but we are close to the margin. Accordingly, we named it marginal placenta. With major previa, partial previa is that the internal OS is completely covered by the placenta, but 3/4 of the placenta is still up further up above. That's why it's partial previa. Complete previa is when the whole placenta is completely at the bottom, covering the internal OS, 50% of it to the right, 50% of it to the left. There is no other choice. It's completely down. And this is the most risky situation for the pregnant, and she has to go under C-section to protect herself and to protect the baby. Placenta previa outcome. So this is a table I have found from research, and I wanted to bring it here to let you appreciate the outcomes from the major and the minor placenta previa as far as maternal outcome and fetal outcome. With maternal outcome, she's gonna have antenatal bleeding, anemia that will definitely require treatment. Pregnant should not be anemic, and postnatal bleeding further than 21 weeks, and hysterectomy in worst case scenario for her. Fetal outcome, there will be preterm delivery for sure, and birth weight below 2,500 gram, or ABCAR score after 5 minutes will be lower than 7, which is also bad, and one of the IUGR restrictions. So what will happen, higher number of the majority of them had preterm delivery with major placenta previa. The major that was covering completely the internal OS, whether complete or partial, and followed by 42% of them had antenatal bleeding with major placenta previa. With minor, the worst was 38% of them had antenatal bleeding and 34% of them had preterm delivery. So with both major and minor previa, majority of the patient had to go under preterm delivery. Risk factors of placenta previa could be prior operation involving uterine cavity or maternal age greater than 35 years old, prior miscarriage with operative management, history of placenta previa are more likely to have previa again. Placenta previa and ultrasound, here you see the cervix, internal OS is closed, and you see the placenta is low. Lower placental edge, internal cervical OS distance should be measuring, and here they did measure the distance from the placenta all the way to the internal OS, as I explained earlier. And here marginal placenta previa, because the placenta is only within the margin of the internal OS, and here is the cervix, and I can tell they did this endovaginally because the tip of the image is curved, and here is the skull of the baby's head. What about vasa previa? Vasa previa is pretty similar to placenta previa, but what happens is at this situation, what's closer to the internal OS is the vessels from the umbilical vein. They protrude all the way into the internal OS. and that you also have to document to the radiologist. Umbilical artery Doppler, this is highly important to understand what's normal and what's abnormal. Type 1 is the normal flow I want for the umbilical artery, as it has low resistance, means we have longer time for diastole flow, whereas in type 2 and type 3, it's really noisy with sharp peak systole. It's finished too fast, too quick, and there is flow below the baseline, which I don't want to have. So the sound wave do detect the movement of blood in the vessels, at this case for the umbilical cord, the umbilical artery. Abnormal Doppler mark placental insufficiency and consequent IUGR or suspected preeclampsia. This is why it's highly important to detect it and know about it. Umbilical artery assessment can reduce perinatal mortality and morbidity of high-risk pregnant. So the normal waveform, as I mentioned, is forward direction, antegrade, all above the baseline, toward the placenta with no flow below the baseline, as you can see in type 2. I don't want to see this. Or absence of diastole is really bad too. So the abnormal show reverse or absence diastole flow before 15 weeks of gestation. This is so bad. So here absence, and here you see below the baseline. The PIAND RI values, the further the gestational age of pregnancy gets, the lower the PIAND RI value you will get. So why is this? I want to see if anyone have any idea. You can type. I am not sure if you are answering really. So I will go ahead and answer. So why? Because the further we go, the more the baby needs to be fed enough, and it's lower to have lower resistant waveform. S over D value decreased with fetal age. At 20 week, the 50th percentile of S over D is 4. By 30th week, the 50th percentile of peak systole over end diastole is 2.83. And then by almost term 40th week, the 50th percentile of peak systole over end diastole is 2.18. So you can see how much the ratio drop as further we go in pregnancy. RI mean value decreased from 0.75 all the way to 0.6. And the PI pulsatility index gonna decrease from 1.27 to 0.9. Abnormal Doppler give heads up to IUGR. So what's IUGR and type of IUGR? We're gonna first of all define the IUGR. And here is the chart that you're gonna look at when you obtain the weight of the baby to see, is it within the IUGR category or is it normal? IUGR is defined as fetal growth to be below the 10 percentile because of genetic or environmental factors, where the abdominal circumference is below 2.5th percentile, that you can obtain also from the machine, with cutoff weight of 2,500 grams. So you're gonna see the majority of IUGR babies are below the 10 percentile, way below 2,500 grams. This is why I put the red box, so you know anyone is above is not within this category. IUGR is the second leading cause of perinatal mortality and morbidity, as it complicates 3 to 7% of all pregnancy. So here is a chart where I want to show you the different type of IUGR, as we have symmetrical and asymmetrical IUGR. So now again, remember when we want to know the growth of the baby, we do the measurement of biparietal diameter, head circumference, abdominal circumference, and PPD. And we started knowing her LMB. So we know based on LMB how far the baby is measuring in weeks. And then we use all of those parameters to do the comparison in between the two. Are all of my parameters going along in weeks as that of the one was provided by LMB? So if they are all the same in any normal patient with no that much of complication, they should be going along together. With symmetrical IUGR, what will happen is all of those parameters will be lagging in measurement in comparison to the one provided by the LMP. Whereas with asymmetrical IUGR, what will happen is only the abdominal circumference will be lagging, whereas the rest of the parameter, head, BPD, and femur lengths will be still giving the exact weeks or close weeks, at least to the one was given by the LMP. So that's what you want to know as a sonographer doing the diagnostic exam in here in the differentiation between the two. As well as for your info to get to know with symmetrical IUGR, the etiology is that there is genetic disorder or infection got transmitted to the baby, and the number of cells are reduced, cell size are normal, and the ponderal index is also normal. Postnatal exam reduction in all parameters. Whereas with asymmetrical happened to be occurring in more cases than the symmetrical IUGR. Asymmetrical has incidence of 70 to 80%. And the number of cells is normal, whereas the cell size is the one that is reduced. The ponderal index is low in contralateral in comparison to the symmetrical one. The ponderal index will be measuring below 2, and there will be a reduction in weight of the baby. So epidemiology of IUGR, the incidence of IUGR is 6 times higher in underdeveloped countries. It differs among country population and race. Large number of IUGR are seen among Asia, which account approximately for 75% of affected infants, followed by African and Latin American continents. Clinical observation and finding of IUGR, as I said again, I have to be doing Doppler for the umbilical artery to see is it within normal limits or there is any abnormality. So S over D is 2.8, which is good. This is normal. Anything within 3 or above means abnormal. Decreased fetal height and fetal movement or biophysical profile below 8 are consideration or signs of IUGR. You want to keep your eyes on them. Reaching grade 3 placenta way earlier than 36 weeks of gestational age. Placenta has different grades, which I am going to talk about in further slides today. So when you see the placenta reaching further stage too soon, you're going to know that, oh, there must be something wrong, could be IUGR. Umbilical artery Doppler will show increased resistance to flow, where even the diastole flow is not going to be that long as I wanted. It might be even absent or showing diastole below the baseline. S over D greater than 3 after 30 weeks of gestational age is abnormal, but the image I provided here, S over D was 2.8. That is within the upper limit of normal, was still normal. And here is a question for you again. In which type of IUGR are all the parameters lagging? All of them are dropped. Is it in symmetrical or in asymmetrical IUGR? Daria, we do have a question. Yeah, there we go. Go ahead, guys. Thank you.
We are at 50%, so I'll give another 5 seconds to respond.
Awesome. You guys are getting this, so that's really good. So in symmetrical IUGR, all of them are lagging, whereas with asymmetrical, only the abdominal circumference would have been the one lagging. So placenta staging and IUGR, as I said, placenta have different grades in the different levels during pregnancy. So in first trimester, the placenta is very smooth. With the chorionic plate is very smooth. There is nothing interrogating. Whereas the further you go in 14 to 15 week of a placenta, there are some hyperacogenicity within the tissue of the placenta, which are representation of prominent vessels. And then by 20 weeks, there is more predominant hyperechoic lines than that was seen in 14 to 15 weeks. Hyperechoic REM, we call them. And by the third trimester, indentation within the tissue of chorionic plate with extensive basal echogenicity, highly vascular at this point, with a distribution of retroplacental and intraplacental arteries can be evaluated also in Doppler. So the ductus venosus Doppler. So for ductus venosus, I wanted it to have the SVD&A waveform. So first line is any normal ductus venosus waveform. Direction, it's the one that directs the oxygenated blood to the fetus heart. That's why we would want to evaluate it. S wave is the time of ventricular systole. The V wave is the opening of the heart valves, whereas the D wave is the ventricular diastole. A wave is the arterial systole. I want to see them, all of them, antegrade flow above the baseline at all of those levels. Absence or reverse of the A wave, the time of arterial systole. If you don't see them, or they are below the baseline, or absent in here, below the baseline, as you can see them here, we call it reverse in the negative direction, are abnormal. You don't want to see this, neither that. And here some people call it the ponytail. If you look at it closely, imagine it as a bunny. So those are abnormal because they mean the fetal has a heart problem, unable to supply enough oxygen to the vital organs. The baby must be delivered at this point. So otherwise the pregnant gonna lose her pregnancy. She's gonna lose the baby if this is not labored as soon as possible. So true or false, absence of end diastole flow or reverse end diastole flow of ductus venosus is a sign of heart failure, and the baby must be delivered right away. Is it a sign of heart failure and we should be aware, or no? True or false?
We're 50%, so I'll give another couple of seconds for one.
Yeah. This is true or false? Okay, true. Awesome, guys. Maybe it's wordy, that's why. So that's all. Those were my references. And I hope it's clear. And I have seen already that whole bunch of people are speaking about the BPD, biparietal.
Yes. I think we should comment on that. There was a bunch of them in the comment box. And
so we do, for me, I do it inner to outer. Biparietal diameter, as I said, why we need to clarify the skull, because you would do inner. Inner means this cursor, the blue one, is posterior to where you see the skull. So the skull, the hyperechoic line, is more anterior than where I put my marker. The markers are posterior to it, inner. Then when we go all the way down, we're gonna go all the way to outer of that. So now it's the opposite. I went more posterior to the skull. So you are basically from inner to outer. I don't know if there are people who do outer to inner or just follow the protocol. Like some people don't like you doing your own protocol. So you don't want to put yourself in that situation. Ask them, what's your protocol, guys? Do you like to do inner to outer or outer to inner? Well, whatever they say, go ahead and do it. I am not going to interfere in this. But when it comes to the head circumference, that definitely you have to be hugging the bone. You are exterior to the lines where you see the skull, the hyperaquoic skull. See, it's more inner. Where are our cursors that we draw by the ultrasound machine are more outer. I hope this makes sense and answered and clarified everybody's confusion. Inner to outer. Why inner to outer here? So this is why it's highly important to clarify the skull, because if you are not clarifying the skull and you are off in your transducer, the skull might even look thicker than what it is exactly. And that's an artifact. So you will be measuring beyond and non-accurate measurement. So I hope this is helpful.
Thank you, Rawan. We have a couple additional questions in our Q&A box. The first one is, could you comment on BPD measurement at the level of the lateral ventricles? That's the first question.
So this is again another question of what I just repeated. So the PPD, as you can see here, it's labeled PPD. So it's telling you a PPD. We did the measurement in both of them, inner to outer. You have to have the falx cerebri, cavum septum pellucidum, and thalami. It looks like a box, looks like 3 line, the CSP, cavum septum pellucidum. So in here, column nephronics, not CSB, is similar to CSB. This is why I am bringing this image too. This is CSB, whereas this is column nephronics. You don't want to confuse the two. So go ahead and review them in your book if you are not sure. You want to see the CSB for sure and the thalami, falx cerebri, and clear skull. So you can, because if the skull is not clear, you yourself, while you are measuring, you're going to really struggle. So where am I going to put this? The skull is really not clear. Well, unfreeze the image and obtain another one. So I hope this is helpful.
Okay, thank you, Rawan. Another question is, what is the cutoff distance for low-lying placenta using either window, TSA or...
Yeah, for low-lying placenta, we would want the placenta not to be way below 3 centimeters. So a lot of OB consultant or radiologist you work with wouldn't be too worried if it's at least measuring 3 centimeters away from how low it is from the internal OS. That's a good question.
Yes. Another one is how to scan ductus venosus.
That I need to bring a video for it next time. I don't know how to explain it actually.
No worries. We can definitely.
Yeah, I will definitely have it published. I will organize this with Daria and have it posted for you.
Wonderful. I think this is all for the questions. I have one more poll for the audience. If you can take a little bit of time to answer, if you will be able to apply what you learned today, this will definitely help us to plan future sessions. Really appreciate you, Rawan, joining us today, and everyone else, thank you for joining us. This webinar is recorded and it will be posted on our website. We also will email you the link and also a feedback survey that you can fill out and let us know if you like the session. provide your comments for future webinars. Thank you so much for joining us today. Thank you again, Rawan.
Thank you so much for your time.
We'll see you next month in March 8th at the same time. Mark your calendars. Thank you so much.
Thank you so much. Thank you everybody for coming.